Okay, we're gonna let Virgil go first. And he's already here. So let's welcome him.
Very much, I'm really happy to be here, albeit online. I scheduled and planned already my trip to come over to the United States, but due to the increasing number of COVID patients in our hospital, we are all on duty these days, so we cannot leave too long out of the hospital because we have to take care of these patients, unfortunately, because of the rising numbers. But I'm very happy to at least be present here online and to share you some data and insights on, let's say, the immune cell function in 11q disorders. And I'm really happy to do that together again with Karen. We've been doing this for many years already, either in the USA or in Germany, and every time I think we show you some data on what about the immune function in patients with 11q disorder. What does it mean for them? What can we do about it? And what is the future with respect to immune disorders in 11q disease? So as I heard already from Ken, there are also new families attending this meeting on your side. So what I would like to do for the next 35 minutes or so is to give you a brief introduction in the immune system. And I'm aware that some of you may already have heard a lot about the immune system, but I really want to take the opportunity to also reach the new families that are here for the first time. So to learn something basic knowledge of the immune system, and then more specifically going into detail in the potential problems that we see in patients with 11q disorders. So I will start with my presentation first, and then after that Ken will take over, and then I think in the end we will have time for questions and answers, because I think the interaction and your questions are most important to us. So as said already, I'm Virgil Dalm. I'm an internist, clinical immunologist, so I am treating and seeing patients, adult patients who have a problem in their immune system, and I will explain in more detail what it is all about. So if we look at this slide, and I don't want you to read it all, and I don't want you to understand it all, but just to give you an insight in our immune system. And I think talking again about COVID over the past years or so, we have heard a lot about our immune system. We have heard a lot about the importance of having a good immune system, an immune system which fights infection. So it fights COVID, but also other viral infections, bacterial infections, fungal infections, parasites, everything that comes from outside, microorganisms coming from outside, needs to be eliminated by the immune system. So the immune system consists of a lot of different components. So cells, you may have heard about them. White blood cells, including B cells and T cells, are very important immune cells in our system, and of course antibodies. So if we look at the immune system, it consists of various cells, white blood cells, and antibodies. And antibodies, of course, play a very important role in defense against microorganisms. As we all know that if you get a vaccination against COVID, your immune system builds up antibodies to protect you against severe disease. So the immune system is a very complex system built of various components, cells, proteins, antibodies, and all together, this is the human immune system. And I always learn my medical students to use this metaphor. I always see the human immune system as, let's so call it, the perfect marriage. Because if you look at the picture here, there are a lot of different players in the immune system, and these players, they have to complement and support each other, because one part of the immune system cannot do without the other part of the immune system. So they have to complement and support each other. There should also be kind of an overlap in function between these immune cells, because if one part of the immune system or one cell type of the immune system is not properly functioning, then another part of this immune system could take over the role of the improperly working part. So there is an overlap in function. As said, these cells have to act together, they have to work together to fight and to eliminate intruders. So the immune system is a complex system, interaction between cells, proteins, to act together, eliminate intruders. And there are very important components is that the immune system has the ability to learn. So, for instance, if I get a pneumococcal infection, so I get infected with a specific bacteria, I can get very sick by that bacteria. But in general, my immune system fights the bacteria, recover, and then I will recover, and the immune system will build up memory. So the memory is there to protect you against a re-encounter with the same bacteria. So the first time when you encounter a specific bacteria, you can get very sick, but then in general, the immune system builds up memory so that you can fight more adequately a next encounter with the same pathogen. Of course, very important is that the immune system recognizes self from non-self. So if a bacteria invades, the immune system has to fight that bacteria. So it has to recognize, hey, this is a bacteria that doesn't belong to my body. I have to get rid of it. And of course, the immune system should not react against own body parts, because then you get autoimmune disease. And lastly, the immune system should be tolerant for things that are not dangerous. Think about allergies, pollen allergies, for instance. It's an overreactive immune system reacting against pollen, but pollen in general are not dangerous. I mean, those are not life-threatening infections, for instance. So there should be a tightly balanced control of the activity of the immune system. So it's complex, overlapping function. They have to work together to fight invading microorganisms. But as you all know, there is no such as the perfect marriage, and sometimes things can go wrong in marriages that we feel or see as perfect, and they don't seem to be perfect at all. So what can go wrong? So in green over here, if the immune system is not properly working, so it's insufficient in controlling infections, we call it an immunodeficiency. So the function of the immune cells is disturbed, and less control of infections, we call it immunodeficiency. And on the other hand, if your immune system overreacts against, for instance, things that are not dangerous, or especially when the immune system is not able to recognize self and non-self, you get autoimmune disease, in which the immune cells overreact against own body parts. Think about rheumatoid arthritis, which is a very common autoimmune disease. It's a disease in which the immune system fights or causes inflammation in joints. So you see that the immune system is tightly controlled, should be tightly balanced to be able to fight infections, to not cause autoimmune disease. So think about a perfect marriage and think about an umbrella. So the immune system is, say, our umbrella against the outside world. So to stop invading microorganisms, including bacteria, viruses, and parasites. So it's a shield or an umbrella to protect your body against microorganisms. And in general, or in the perfect balance, the immune system should be balanced as well. And there is not such as increased infections. And on the other hand, there is no autoimmune diseases. So in a strictly controlled and a strictly balanced immune cell function, there are limited infections and no autoimmune diseases. So if we look at the immune system, we can use all kinds of metaphors like the marriage, like the umbrella, protecting you against the outside world. But when it comes to the immune system in more detail, there are some specific components that we need. And I want to show you in a few slides what are the components to just make it a bit more visual, what happens when your immune system or your body gets invaded by microorganisms. So we have different white blood cells, as already mentioned in one of the first slides. So these white blood cells, those make up the cells of the immune system. And on this picture, you see one of these cells. We call it phagocytes, and phagocytes means eating cells. So that's what these cells actually do. So they recognize, again, so they have to recognize a bacteria, which should not be in the human body. They recognize as being foreign, and the attacking cell, or the phagocyte in this case, eats the bacteria. And I will shortly play this video. You see here, this phagocyte is chasing the bacteria, the black little thing, chasing the bacteria, and eventually he finds it, he guts it, and he destroys it. As you see over here, he's still chasing the bacteria, finding the bacteria, and eventually engulfing it and destroying the bacteria. So this is our what we call simple immune system. So these cells just recognize, let's say, self from non-self. So a bacteria enters your body, enters your bloodstream, for instance. These white blood cells just find the bacteria and eat it. And this is a very primitive reaction. So every time you get infected with bacteria, this process starts all over again. These cells start chasing bacteria and destroying them. But what you actually want, of course, after a first encounter with the bacteria, that the next time you get the same infection, your body will react with less severe disease. So one of the most important things of the immune system is that you need to build up memory. So memory against previous pathogens. So if you have encountered a bacteria once, on the second encounter, you hope and you that your immune system has built up memory, so it directly can fight the bacteria that is invading the human body. So for that memory, we have our more what we call adaptive immune system. So that's the immune system that has an ability to learn, has an ability to develop over time, which is in contrast to the cells that you just saw, which are just made to find bacteria straight away. So what are the other white blood cells that we need for our proper immune cell function, which those are T lymphocytes, also a class of white blood cells. Those are heavily involved in clearance of viruses and fungal infections, and they support the B cells. So here again, showing the importance of interaction of these cells in the immune system. So one cell cannot do without the other. So T cells mainly for clearance of viruses and fungal infections, and then we have the B cells. And the B cells, those are the white blood cells that produce antibodies. So again, referring to antibodies that we detect after COVID vaccination, those are antibodies that have, let's say, a Greek Y-shaped pattern. So these antibodies, they can bind to, for instance, bacteria or viruses, and by binding, they activate other immune cell functions, and in that way, the bacteria or viruses are removed from the bloodstream. It's shown on this picture on the left. So what you see here is a pathogen, the blue ball, and you see those antibodies. Those antibodies recognize a pathogen, and they can bind to it. And if you look in more detail, I can show you this animated video, which I always find very informative, because it truly reflects what is happening. So this is, imagine you are in the bloodstream. So this is the bloodstream with all kinds of white blood cells, red blood cells, thrombocytes, and those are going around your body. And here is one, let's say, a bacteria that is in the bloodstream, and it is floating around. And because it is a stranger, it is recognized by other immune cells. So other immune cells attach to the pathogen, and also antibodies produced by B cells start attacking those bacteria, and then the bacteria gets removed by other cells. So this is actually how antibodies work. These are produced by B lymphocytes. Those antibodies find bacteria, and then the bacteria are removed from, in this case, the bloodstream. So if we look at the immune system, we has various components. We have these very primitive cells that eat bacteria. We have the T cells that help B cells, and then the B cells that produce antibodies, and the antibodies are able to attach to bacteria, and secondary, those bacteria gets removed from the bloodstream. So the immune system is quite a complex system, and we have to consider that we need all these components to keep our immune system balanced. So we need all those cells, we need all those antibodies, we need them all to have a stable and normal immune cell function. And in the human body, there are different organs that all constitute the immune system. So we have the tonsils in the ENT region, and we have lymph nodes spread throughout the human body where lymphocytes, white blood cells develop and are stored, but also the liver, the spleen are major sources of our immune system, and the bone marrow, as depicted on the lower left, is where all the buildup of these cells is done. So actually, our immune system is everywhere throughout our human body. So we're talking about the umbrella providing protection against pathogens, but what if something goes wrong? So imagine yourself, an umbrella with holes in it doesn't protect you against the rain. So an immune system with holes in it doesn't protect you enough against bacteria, viruses, or other infectious complications. So if we look at problems in the immune system, so let's say holes in this umbrella, holes in the shield of protection, we can get infectious problems. And we were just talking about B cells and antibody production. So remember the antibodies that were sticking to bacteria. So one of the major problems that we see in clinical practice with immune cell function is the loss of these antibodies. So there are patients that do not produce enough antibodies or do not produce antibodies at all, or the function of these antibodies is reduced. So imagine again the video. So these antibodies are required to attach to bacteria or viruses, and then the bacteria can get removed from your body. So if you do not have antibodies at all, or lower amounts or lower levels of antibodies, or these antibodies do not function well, you have an increased risk of infections because you are not able to clear those infections as properly as someone else. So what do we see then in these patients? So this is just an example. Don't try to read it all. And but the only thing is that what I would like to show on this slide, that some patients do have an absence or a decreased production of antibodies. So the antibodies are absent, or the production is lower, and patients have a disturbed antibody function. So they don't work as well as they have to. And what you see on this spectrum is on the right side, healthy individuals who have normal levels of antibodies. So they produce the normal amount of antibodies, and the function of the antibodies is normal. And but completely on the left side is a disease that we call X-linked agammaglobulinemia, which is a disease found in boys because it's an X-linked disease. So the genetic defect is on the X chromosome. It only happens in boys. And those are children that do not have B cells at all. Due to the genetic defect, they do not produce B cells. So they also do not produce antibodies. So their defense against bacterial infections is highly impaired because they don't have the antibodies to get rid of those infections. So these are generally children, boys, as said, that present at a very early age with recurrent severe infections. So they have recurrent infections with the same pathogen because the immune system is not able to build up memory. So not able to build up memory B cells and antibodies to provide protection against these bacterial encounters. So between XLA and healthy controls, there is a lot of other diseases, some of them with lower levels of antibodies, some of them with normal levels of antibodies, but only disturbed function, but all antibody problems resulting in an immune deficiency. And what kind of infections do we see then? Because I'm talking about B cells, talking about the loss of antibodies or disturbed antibody function. And what happens to children or adults when they have a disturbed function of these antibodies? Well, these patients get recurrent infections. And very typically, those patients have an increased risk of infections of the ENT region, so ear, nose, throat region, sinopulmonary tract infections, so repeated lung infections, upper respiratory tract infections, sinusitis, for instance, and also an increased risk of gastrointestinal tract infections. So very typically, if the antibodies are lower or they do not function well, those patients have increased risk of infections, particularly of the upper and lower respiratory tracts. But also other more severe infections may occur, including abscesses, for instance, skin abscesses, or also infections of the bones. But most importantly, what we should take into account, recurrent sinopulmonary tract infections are key clinical problems in patients with a lower production or lower function of antibodies. So which is again summarized over here. So a very brief, maybe it's sometimes difficult to understand it all in such a short summary, but in general, I try to show you some basic major components of the immune system. So those are cells, those are antibodies that all have to build the immune system to provide you protection against fungal infections, viral infections, bacterial infections, and so on. So the question, of course, arises, why are we discussing this issue here? Why are we so interested in immune cell function in this particular day? And it is because there is indeed some evidence, and that also in 11q disorders, a number of patients suffer from immune cell defects. And that's what I will discuss in the upcoming slides, show you some examples and show you some data that we have gathered over the past few years. So these are actually two pictures from patients from an outpatient clinic. So on the upper left, these are pictures of an adult patient with multiple warts, as you can see on his hand. And of course, warts are very common because we all have had warts at a particular stage of our lives. But if you see a person, an adult person, especially with so many warts on his hand, then you should think, well, there should be something wrong with the immune system, because this warts is a viral infection. And normally, when your immune system develops over time, you may see warts in childhood, but over time, when your immune system gets better and better, you should not have these many warts on your hands. So if you see these kind of pictures, or we as a doctor should be aware that might be something wrong with the immune cell function, because normally you would not see these viral infections being so severe at an adult age. And on the other hand, a picture, an X-ray from a patient with a pneumonia, as depicted over here. So this is the lung tissue on the left lung, and on the right lung, you see that the lung tissue is only black over here, but in the top, you see a pneumonia. So this is a typical picture of a severe pneumonia. So these are some examples of infections in 11q disorders, and it was already published many years ago, almost 20 years ago, by Paul and colleagues when he described clinical findings in the 11q terminal deletion disorder. And they already found that in around 50% of patients with the 11q terminal deletion disorder, recurrent infections were important clinical features. So more than half of the patients suffered from recurrent infections, including, for instance, upper and lower respiratory tract infections. So it was already recognized at that time that a lot of patients indeed have infectious complications. And after that initial publication, other publications appeared across the world describing a series of patients, or just sometimes one patient, with an immunodeficiency and recurrent infection in, for instance, Jacobsen syndrome, as shown over here. So 20 years ago, the first publication that showed indeed an increased risk or the increased presence of infectious complications in Jacobsen syndrome. And following that initial publication, other groups around the world also found children and adults with Jacobsen syndrome also having higher numbers of infections. And actually in 2014, it was the first time that I met two patients with Jacobsen syndrome who were actually referred to my outpatient clinic by the pediatrician of our hospital, because he said, well, this young guy, he has multiple warts on his hands, he had recurrent pneumoniae, is there something wrong with the immune system? And then I was not aware of the syndrome at all. I have to admit, I have never heard it. I had never heard of it before. So I was looking into literature. What is it? How is it caused? And is there some link between the warts, the pneumoniae, and the Jacobsen syndrome? And then you always have those come together. Within 1 month from the first patient that I met, I saw a second patient in my outpatient clinic with Jacobsen syndrome and recurrent infections. And I thought, well, this could not be a coincidence. There should be some relation between the Jacobsen syndrome and the immunodeficiency. So I dived into literature. I found the papers by Paul and the other papers. I thought, well, there is indeed, or there should be indeed, a link between Jacobsen syndrome and the immunodeficiency. So what we did in the Netherlands at that time, we collected in total 6 patients who were known with an 11q disorder. We invited them at the outpatient clinics. And as you can see here, these 6 patients, all but one, suffered from recurrent infections. So all of the patients, if you listen to them and listen to the parents, they say, well, they are always upper, lower respiratory tract infections. They are admitted in hospital multiple times a year because of a pneumonia. So they all suffer from infections, some only mild, other more severe. So there's also a spectrum, let's say, in the clinical presentation. But very, very important that 5 out of 6 indeed said or recognized the increased risk of infections from a clinical perspective. Most importantly, as shown over here on the right, those patients reported upper, lower respiratory tract infections. And as I just mentioned on one of the previous slides, these kind of infections, if you look at the immunodeficiency, are mostly related to lower levels of antibodies. So again, B cells producing antibodies important for preventing upper and lower respiratory tract infections. And these patients suffer from these kind of infections. So the initial thought was, if there is an association between Jacobsen and an immunodeficiency, could it be related to antibody production? Because these infections suggest an antibody defect. So what we did in these 6 patients, as shown over here, we measured antibody levels. And antibodies, we also call it immunoglobulins, and is here in short IgG, IgA, and IgM. And in bold, you see which levels are lower when compared to normal reference ranges. So in general, the level of IgG, so we focus for this IgG in the upper bar. IgG levels should be between 7 to 16 grams per liter. And if you look here, 5 out of 6 of the patients had IgG levels that were lower than normal values. So very clearly, 5 out of 6 patients have recurrent infections, and also the same number of these patients had lower levels of immunoglobulins, lower levels of antibodies. And these antibodies are produced by B cells. So here we looked at the total number of B cells of patients with Jacobsen on the right versus control people, so healthy controls. And what you see, and just look at the picture, you can see that in Jacobsen patients, the numbers of B cells that produce antibodies was lower. So indeed that fits. You have lower numbers of B cells, which produce lower levels of antibodies, which give rise to an increased risk of infectious complications. And in more detail, maybe even more important, B lymphocytes can be divided in all kinds of subsets. For instance, we have memory B cells, and the name already says it all. Memory B cells are responsible for immunological memory. Again, if I get infected with the bacteria, I can become very sick or very ill. But in general, my immune system builds up memory B cells, that in case I get a second encounter with the same bacteria, these memory B cells can directly get activated and fight the infection very quickly. So these memory B cells are important to prevent you against severe disease upon recurrent encounter with the same pathogen. So immunological memory is very important because it protects you against getting severely sick by the same pathogen over and over again. So a long story to show and tell you that indeed in patients with Jacobsen syndrome, so again, the 6 patients that we evaluated at that time, these patients have low numbers of memory B cells. So they are very low, actually, as you see here on the right, when compared to the healthy controls who are on the left. So the memory B cells, important for immunological memory, are very low, which gives potentially an increased risk of getting sick or getting disease by the same pathogen over and over again. So very clearly, I think from that study in 2015, we found that the B cells were low, memory B cells are low, antibodies are low, infections are high in patients with Jacobsen syndrome. And over the past few years, Jacobsen syndrome has also by the International Union of Immunological Society has been recognized as an immunodeficiency. So based on the studies that I just showed you, starting from the study by Paul and until this one, eventually we all recognize Jacobsen syndrome as an immunodeficiency because it's an important part of the syndrome. So we're just talking about B cells. And some of you may already have seen some data from this recently published research, which was done by Dr. Huisman. She's a hematologist from our institute, a pediatric hematologist. And she's also involved in care for patients with Jacobsen syndrome. And she has recently also given a presentation at the Pforzheim meeting in Germany. But because we were looking into B cells and the antibodies, but we also found, for instance, the patient with the warts, which is a viral infection. And we know that viral infections need to be eliminated, for instance, by T lymphocytes. So the question is also, is there something wrong with T cells? So we did a second study 7 years after the study in 2015, looking in more detail in T cells. And you see here that we included 14 patients with various 11q disorders, So not only, let's say, the typical Jacobsen syndrome disorder, but also duplications on 11q, for instance. But there were around, 14 patients included in the study. And what we found here is that indeed a number of patients suffered from infections, pulmonary tract infections, but also viral infections. And you can see, I will just show you some specific parts of this table. So there are a number of patients included. And if you look at infections on the third column, you see that almost all patients say, well, I have a lot of infections. And when parents say, well, if I look at my child with Jacobsen, for instance, and compare it to my other children, they have lots and lots of more infections than the other ones. So it's very clear that the majority of patients with 11q disorder suffer from recurrent infections. So we already knew over here, the IgG column, that a number of patients had lower IgG levels, but also a number of patients have normal levels of immunoglobulins. But then if you look at the T cell function, so the function of the T cells, when we test it in the blood or in the laboratory, you see that a lot of patients have a decreased function of T cells. So these cells do not work properly. And if they don't work properly, you have an increased risk of infections. And I think it's very important to note here, to make it even more complicated, if you look at the number of patients that have a disturbed T cell function over here, inadequate, 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 all but one have a lower function of the T cells. But if you look at the number of T cells, depicted over here, TC count, to the T cell numbers, those are normal in around 50% of patients. And what we generally do when we see patients in clinical practice, we measure the numbers of B cells. We measure the numbers of T cells. We measure the levels of immunoglobulins. But I think this is very strikingly showing that measuring numbers alone is not or could not be sufficient, because not a number of these patients with normal T cell counts have disturbed function. And I will come back to that later, but it's something to keep in mind when you go to a doctor, they take your blood and say, it's all normal because B cells are normal, T cells are normal, antibodies are normal. But if you still have the feeling, well, there's still something wrong with the immune system, because despite being all normal values, there could be something wrong with the function of these cells. So if we look at all the data over the past 20 years, I think we can conclude that a large number of patients with Jacobsen syndrome suffer from recurrent infections. If we look in more detail, we see that low numbers of B cells are found, especially memory B cells. As said, those are important for building up immunological memory. Patients have low antibodies. And based on these findings, I think this could be the explanation why these patients suffer from increased risk of infections, pulmonary tract infections, gastrointestinal tract infections. And because of those findings, I would say, and I hope that is supportive, that all patients with 11q disorder or Jacobsen syndrome require immunological evaluation, because we see in a significant number of these patients that they have those increased risk of infections. And we see in a significant number of these patients that there is indeed in the evaluation of the blood that there are signs of low levels of immune cells and antibodies. And of course, what do you need to do then? Because if you have a disturbed function of the immune system, that's something that we cannot restore. We cannot give medication to improve the immune cell function, to elevate the number of immune cells. So the problem is that we can only try to start preventive measures, so including antibiotic treatments or sometimes even antibody infusions, because if these antibodies are low or the antibodies are not functioning well, you can provide antibodies from healthy plasma donors. So, but again, I would say that normal levels don't tell you all, because as shown on one of the previous slides, in some patients, we find that the values are normal. So the T cell counts are normal, B cell counts are normal, immunoglobulin levels are normal, but there could still be a disturbed function of these cells, which still would also result in an increased risk of infections. So if values are normal, but you still have a high suspicion of an underlying immunodeficiency, functional testing should be performed. Do the tests to show whether these antibodies or cells function properly. And of course, and that's also something that you always have to remember, consider an underlying immunodeficiency based on the clinical picture. If you see a 25-year-old male patient with warts on his hand and his feet, that's not normal. That is not something that we see in general. That suggests there is an immunodeficiency because of an inadequate control of HPV infection. So looking at the patients, looking at the history, looking at the infections should raise suspicion for an immunodeficiency. So a short introduction on the immune system. The major findings of immune cell dysfunction in patients with Jacobsen syndrome, B cell defects, antibody defects, T cell defects, increased risk of infections, cytoplasmic tract infections, viral infections, warts, as shown on the picture, may be seen. Then, of course, also COVID-19 hit the world. And of course, for patients with immunodeficiencies, there was a lot of concern. What would happen with us if we got infected with COVID-19? Because if our immune system is not working properly, we have an increased risk of infections in general. What about COVID? Would it be worse in us? Would it be result in more severe disease? So for the next few minutes, I would show you some data about COVID. And of course, there are many aspects of COVID-19 in patients with immunodeficiencies. Of course, the fear or anxiety about getting infected. What would happen with me? But is it indeed the case that patients with primary immunodeficiencies have more severe course of COVID-19? What happens or what could happen if we got infected? Is there treatment for us available? And of course, one of the latest measures that we have against COVID-19, of course, vaccination. But would that make sense in these patients? So I just briefly touch upon some aspects of COVID-19 in patients with immunodeficiency, and I consider Jacobsen or 11q disorders in general as immunodeficiency as well. Of course, one of the first things about impact of COVID-19 on patients with immunodeficiency, we always think, okay, they are afraid of getting the disease, they are afraid of getting hospitalized, they are afraid that they don't have therapies to treat them well. But one of the things that we always tend to forget is that also that lockdown, because we know that a lot of patients with immunodeficiencies were in quarantine for almost 1.5 years. They didn't go out. I have multiple families with a primary immunodeficiency that have been at home for the past 2 years. They haven't seen anyone outside. They haven't been to school. They haven't been to work, just to prevent themselves or to protect themselves against infection. So that has a lot of impact on psychological well-being, and it is depicted on this slide. Just one of the studies that I took, showing that there is a negative impact of lockdown or isolation on patients' well-being. So we have to take that into account, because we say, okay, you have to stay inside, be careful, don't get infected, but think about the psychological impact of those kind of decisions. And not only with the patients, but also with the parents of the patients. And so also anxiety, post-traumatic stress disorders are higher in parents who have children with immunodeficiencies. And we all know these kind of pictures. So hospitals full of beds, COVID patients admitted. But what about the severity of COVID-19 in patients with primary immunodeficiencies? So this was actually one of the first studies coming from Israel, in which they had the first initial studies published. And they have a lot of good registries, and they have around 1,700 patients with primary immunodeficiencies. And in the first wave of COVID, so from the start of 2020 until the summer of 2020, only 20 of these patients with primary immunodeficiencies were tested positive, while approximately 2 to 2.5% of the general population was tested positive. And of course, a lower percentage of positive patients, of course, due to the measures they took, because patients with primary immunodeficiencies, they tend to go in quarantine or isolation much better than patients who are healthy. But at that time, the most remarkable thing is, albeit only 20 patients, none of these patients had significant symptoms or were admitted in hospital. If you look at other studies, so this is a paper from Brazil, also from 2020, to patients with an immunodeficiency, 120 patients who got COVID, and in January they had only mild symptoms, although there was a higher risk of dying from COVID than in the healthy population. But the severity of COVID was not related to the immunodeficiency, but more related to the general comorbidities, like, for instance, diabetes, elderly age, being a man, were the risk factors that we also see in the general population. It was until 2021, until this overview came out as describing patients with antibody deficiencies that had an increased risk of severe disease after infection with COVID-19 in patients with chronic underlying lung disease. So if patients have an immunodeficiency and lung disease, they have an increased risk of severe disease. So what about COVID-19 in immunodeficiency patients until we know so far? So those are the primary immunodeficiency patients. We see a relative low numbers of infections because patients are aware, they take the measures more seriously. But in the majority of patients, we only see mild symptoms, but severe disease in specific subgroups. Sometimes not immunodeficiency related, so depending on hypertension, diabetes, male gender, and the common risk factors. And sometimes we also see an increased risk of severe disease in patients with lung disease or immunosuppressive treatments. So some final slides, because what do we do, or what do we need to do with vaccination in those patients with primary immunodeficiencies? And of course, a lot of studies have been published showing the effects or the efficacy of vaccination in patients with primary immunodeficiencies. And in the Netherlands, we performed this study, vaccination against COVID in primary immunodeficiency diseases. It was a study that was performed in 500 patients with a primary immunodeficiency. And as you see, you recognize those names: CVID, IgG subclass deficiency, XLA. Those are patients with lower levels of antibodies. So they do not produce enough antibodies, or antibodies are not functioning well. So what happens if you perform vaccination? And this looks like a very busy slide, but I just want to show you here on the left, the green dots, those are healthy controls. So this is the antibody production after vaccination in healthy controls. And now you should recognize here XLA patients, they do not have antibodies. So also after vaccination against COVID-19, they don't have antibodies. They stay around zero, as you can see over here. So normal controls, antibody production, yes. XLA patients, as expected, they don't have antibodies, so also not after vaccination. But if you look in other immunodeficiencies, you see that patients, a lot of these patients just produce antibodies, and even in some subgroups compared to the normal population. Very importantly, if you look at this bar, so the blue bar, blue purple bar, those are patients with CVID, so common viral immunodeficiency, lower levels of antibodies, and you see that a lot of patients produce antibodies after vaccination, but some of them are also here, like this XLA, are very low or almost zero. So there is a number of patients with an antibody deficiency who do not respond to vaccination regarding antibody production. Fortunately, most of the patients that we tested all produced T cells. So again, to provide effective immunization, you have to build up antibodies, as shown on the previous slide, and T cells, as shown on this slide. And most of the patients produce T cells comparable to healthy controls. But also here, again, is a subgroup of CVID patients that do not produce antibodies and do not produce T cells. So these are the patients, you can get them vaccinated, but they don't build up antibodies and they do not have T cell responses. So those are still vulnerable patients after vaccination. So these were the conclusions of this study. Again, XLA, of course, no antibody response, but a normal T cell response. So they could benefit from vaccination, not because of the antibodies, because they don't make it, but they do have a T cell response. In the mild antibody deficiencies, it's comparable to healthy controls. So they have antibodies, they have T cells, but this again, so in the middle, the CVID patients, there are a number of patients that don't have antibodies, they don't have T cell response after vaccination, so you cannot protect them effectively by getting vaccinated. What are those patients? Well, those are the patients with other immunodeficiency related complications. So these are patients with autoimmune disease, prednisone usage, inflammatory diseases. So those are the patients with more complicated disease. So we can identify the patients, fortunately, that respond less well to vaccination, but still, of course, it is difficult. What should you advise them regarding vaccination and treatment? After 6 months after vaccination, what we see is that antibodies and T cell response decline gradually, as is seen in healthy controls. So if you can get vaccinated and you have an antibody response and T cell response, it stays over time comparable to the healthy controls. So conclusions on the COVID, we see in patients with immunodeficiency from very mild to severe disease. The risk is associated with the underlying disease, potential comorbidities, treatments. Treatment options, of course, are sometimes limited. Some of these patients that are admitted in the hospital can be treated with plasma again. So those are antibodies collected from patients who got vaccinated and or infected themselves. So you give them antibodies from healthy donors. Sometimes we can what we call use monoclonal antibodies. So for instance, the RegCov, which are antibodies directed against the virus. So in patients that do not build up antibodies themselves, monoclonal antibodies can be used. And when we look at the vaccination efficacy, vaccine response are very variable across the diseases, but the most of the patients with immunodeficiency show a good response. The question is, of course, is it enough? Because we see that some of these patients build up antibodies, they build up T cells, but still end up in the hospital because of severe disease. So it doesn't say it all, of course. And the question is there, how should we continue vaccinated those patients? So in the Netherlands, those patients with immunodeficiencies get a booster every 3 months to increase the levels of antibodies. The question is that sufficient? And we know that in some patients, even the 3rd, the 4th, the 5th booster doesn't result in antibody rise at all. So the question is, how do we prevent those patients from getting the disease? So with that, I'd just like to give a short thanks to all the academic hospitals that have been collaborating, and especially in the vaccination study, and also the patient organization for primary immunodeficiencies. And with that, I would like to end my part of this presentation. Thank you.
Can you hear me, Virgil?
Yes, I can hear you very well.
Excellent. Okay. So the way this is going to work is Virgil actually has my slides and he's going to drive my presentation. So I'm going to ask him to advance as I need him to. And at the end, we're going to open it up to questions, and Virgil and I will tag team the audience questions, and Cole is going to run the mic, right?
Mhm.
Okay, so we're going to have a team work session at the end. So let's see, Virgil, can you pull up my first slide?
You see it or not?
No, I don't. Can you guys see it? Nope. You might have to close your,
Yeah, I think you need to unshare it. and then
Yeah.
reopen, and then
yeah,
reshare it.
unshare it and then reopen it.
Yeah.
There we go.
Yes.
Perfect. So typically when Virgil and I have done this before, there's been a lot of overlap. And it's almost the same talk back to back. So this time we sort of got together and he presented a lot of the basics. I'm going to review just a few slides just so everyone remembers that, because I think there's a few things that I want everyone to go home with and remember to be able to regurgitate to their pediatrician or to their immunologist. And then I'm going to talk a little bit about what we can actually do for our patients with Jacobsen syndrome, especially for some of those patients who are in their first few years of life when the immune system is actually developing and changing. And there may be an opportunity to do some evaluations to help get a baseline of where people stand and what the future might hold. And then I'm going to go over that protocol and maybe talk a little bit about ways that I think Virgil and I might need to tweak that protocol, since it's been a while since we've really looked at it critically. And as you can see, there's been some new information coming out. And then also new information about COVID, right? So maybe that protocol needs to include a little bit of recommendation from us about what our patients, and your family members need in regards to protection from COVID. So the T cell is probably one of the most important cells for you guys to remember when you go home from this meeting. Think of it as the communication cell. And if the communication cell isn't functioning well, like Virgil talked about, or if it's not present in the normal numbers, the immune system isn't able to function normally, and it's especially not able to adapt. And the adaptation to new infections and to be able to develop that memory where it can work harder and faster and stronger with subsequent exposures to bacteria and viruses is super important. And if it can't do that, we're going to get recurrent infections like many of the patients here have. T cells are super important in protection against viral infections. They can do that directly as well as through the B cell with communication. So if the T cells don't function, you're going to have recurrent viral infections like the warts that Virgil mentioned, like the fungal infections. I know a lot of patients have on their feet and in other moist areas of their body where they might get thrush or other forms of ringworm. T cells, super important. That explains why your family members with Jacobsen syndrome have those issues with fungal infections on their toenails, maybe oral thrush, and especially with warts. Next slide, Virgil. The B cell, as Virgil mentioned, also super important in protection against infections. We know that the B cells in Jacobsen syndrome are probably present at lower numbers, especially the memory B cells, but we don't know why they don't work well. We haven't figured out exactly what part of the Jacobsen syndrome impacts that B cell function. Next slide, Virgil. And because the B cells don't work and the T cells don't work, many patients with Jacobsen syndrome have varying levels of antibody deficiency. Some patients have low IgG. I know at least one patient who makes absolutely no IgM. And then some patients have low levels of IgA or low levels of any one of those three different types of antibodies. So IgG, IgA, and IgM are the different immunoglobulins that we need to measure in our patient's bloodstream. Virgil talked about this, how specific those antibodies are and how it takes exposure of those B cells and T cells to either bacteria, viruses, or vaccines in order to be able to make those antibodies. And then those antibodies function in multiple different ways. Virgil showed a video of the ways those antibodies stick to bacteria or viruses, and then how other immune cells will engulf or eat the bacteria once the antibodies are stuck on there. But those antibodies can also directly neutralize toxins that bacteria or viruses make. And then also can actually help prevent those viral infections from developing rapidly once you're infected. Next slide. Okay, so a few years ago, at Paul's request, Virgil and I put together a protocol for patients with Jacobsen syndrome for parents to have with them when they went to physician appointments. And it gave some recommendations, and still does, for patients with Jacobsen syndrome at various stages of their life and development. And it starts right at the newborn period. So I know we have some new families who have very small children, and those children were born within the last few years. And if they were born in the United States, they received a newborn screening test the day after they were born. And that's that heel stick where they take a few drops of blood and they do genetic testing, essentially, or genetic screening, looking for, depending on what state you live in, a whole bunch of diseases that can impact a child's life very early and for which there are known treatments, right? Because you want to identify those diseases early so you can intervene and stop any chances for severe illness or potentially death in those individuals. One of those screening tests looks at the number of T cells in that baby's bloodstream. And it was designed to identify a very severe immune deficiency called SCID, or severe combined immune deficiency, which is fatal if it's untreated. But when that screening test came out in, let's just say, around 2010, whether it was on a research basis or starting to be rolled out to certain states who wanted to implement the test, we very quickly realized that occasionally a patient with Jacobsen syndrome would have an abnormal newborn screen for T cells. And we realized that around the same time that I met Paul, that meant that patients with Jacobsen syndrome had a T cell problem. Not every single patient had very, very low T cells, because clearly there are patients who maybe didn't have an abnormal newborn screen, but there was something up with those T cells. And so part of our recommendations in this protocol are, if you, at this point, not every state was getting newborn screens. Every state in the US now screens for T cell deficiencies, so it's not an issue. But we want to make sure that every infant or very young child has a screening test for T cell number, and that's called lymphocyte enumeration, or a lymphocyte subpopulation test, where we will be able to understand how many T cells are present in that baby's bloodstream, how many B cells are in that baby's bloodstream, and in some cases, how many of those memory B cells are present. Virgil did allude to the fact that that number isn't the whole story, and that we also need to maybe do some functional testing on those T cells, but the newborn period is not necessarily the best time to do those functional tests. So at this very young age, it's important just to get a T cell enumeration panel or a T cell or lymphocyte subpopulation test to see how many T cells are present. During the first few months of life, the baby's immune system will develop and be able to make those antibodies after T cells and B cells start to communicate. And so around the age of 4 to 6 months, I think it's important for all children with Jacobsen syndrome to be able to get a immunoglobulin level. And we measure IgG, IgA, and IgM. And those are just big total numbers of those antibodies, sort of like the test that was on one of Virgil's slides where he showed that the IgG level was lower in patients with Jacobsen syndrome, but didn't actually show that they were missing antibodies against specific bacteria. So it's more like just finding out that the gas tank is either full, 3/4 full, or empty. Around 12 months of age, we do have the ability to measure whether your children have responded to the vaccines that they've received. And we can measure, just like we measure anti-COVID antibodies now, right? We have always been able to measure whether your children have responded to their tetanus vaccine, their diphtheria vaccine, right? Haemophilus influenza, which is another type of vaccine children get in that first year of life. We can make sure that those T cells, B cells are talking to each other and your children are responding to those vaccinations. Some children with Jacobsen syndrome might not respond well to those vaccines, and we'll know that around the age of 12 months. At 2 years of age, that's a super important time to do what I think is one of the most, I'll use the word important again, most important tests to see how your immune system is functioning. And that's where we can immunize a child with Pneumovax, which is a little booster vaccine that all kids with chronic diseases can get, that protects against pneumonia and infections with a bacteria called Streptococcus pneumoniae. We immunize kids, we measure their antibody production 6 to 8 weeks later, and we can either prove to ourselves or reassure ourselves that the immune system is functioning normally and making antibodies, or we can get an understanding of how deficient the immune system is in its lack of ability to make those specific antibodies. The combination of all of these test results will help immunologists like Virgil and myself decide what type of interventions we might need to do to protect kids from infections. Next slide. And so some of those interventions might be listed here on this slide. So I think it's important that all kids have at least a consultation with an immunologist or identify somebody in your area. That would be, in the US, we would call them allergist immunologists because the fellowships are trained, are combined. We learn about allergy and immunology. In other countries, there may be a little more separation between allergists and clinical immunologists. We always use vaccines to help promote the health of children. And in general, almost all vaccines are safe for patients with Jacobsen syndrome. The only exception to that would be in the first few months of life, if you didn't have a T cell screening test at birth. So if you didn't get that newborn screen, there might be a reason to avoid a live viral vaccine. One is called rotavirus, or around the age of 1 year of age, you get MMR or varicella vaccine. That is no longer really an issue because all children are screened for T cell deficiencies. So we don't have to worry so much about not immunizing in the first year of life anymore because everyone is being screened. Around, I'll say, a couple months of age, we'll have an idea if there's a T cell problem or not. And that might help us decide whether we need to use Synagis, which is an infusion of monoclonal antibodies to prevent a very common respiratory disease called RSV. Other children get Synagis to prevent that infection, but those children are children who typically have pretty severe cardiac disease. And Paul might touch upon this in some of your meetings with him. But because we had heard about a patient with Jacobsen syndrome who had an RSV infection and did not do well after that infection, we thought it might be important in this protocol to recommend the use of Synagis to try to prevent that infection. It might be a little bit difficult for you to advocate for that because there's some strict guidelines to the use of Synagis, but we've been pretty successful in getting insurance companies to allow for us to use Synagis in patients who have Jacobsen syndrome and where we can document a T cell deficiency. And then also, I consider the use of that Pneumovax, or Pneumovax 23 is the other name of it, almost like an intervention to promote health and not necessarily only a test to determine whether somebody's immune system is functioning well. The vast majority of children respond to that, even if they have Jacobsen syndrome. And what that does is improve their ability to fight off infections with that very common bacteria. So using Pneumovax is considered to be both really diagnostic in some cases, but also therapeutic in most cases. Next slide, Virgil. Okay. And here's some other interventions or ways that I think the protocol can help you advocate for your children. So I think it's super important to have early treatment with antibiotics if your kids are sick. In general, pediatricians tend to avoid using antibiotics unless there's an infection that they're really sure is caused by a bacteria. In the general population, I think that's a fair strategy because most kids don't get severe complications. They recover from ear infections without antibiotics. They might have a sinus infection that's really a virus anyway. But if we know that we have a patient sitting in our office who has an underlying risk for more severe disease or an underlying immune deficiency, as Virgil alluded to, we consider Jacobsen syndrome to be a syndrome with immunodeficiency as part of it. It's important to use antibiotics earlier in that course of illness than we would otherwise. It's also important to use those antibiotics at higher doses and for longer periods of time, rather than that typical 7 days of antibiotics for an ear infection. In a patient who has an antibody deficiency, I might treat for 14 days or even longer, assuming that they're not able to respond to, their immune system's not able to respond normally to that type of infection. And I would also choose probably the second line antibiotic rather than straight old amoxicillin. So rather than getting that 7-day prescription for amoxicillin, in a patient with an antibody deficiency, I might choose 14 days of Augmentin, right? And I would also choose one of the higher dosing regimens for Augmentin than I would with a patient who has a normal immune system. So some of those are interventions and ways that I think this protocol can help direct a pediatrician who might not necessarily be familiar with immune deficiencies to treat appropriately and help to clear out infections quicker. One thing we had on here was to repeat the immune evaluation if infections are recurrent or severe, or maybe if changing. We know that some forms of immune deficiency evolve over time, and Jacobsen syndrome might be one of those, where over time, the original production of antibody might have been normal, but becomes deficient or abnormal with age. We can't necessarily predict that yet. We haven't been looking at it long enough. But what we know about some of the other forms of immune deficiency is that that is not completely out of the question or unusual. The other thing I want to advocate for is using prophylactic antibiotics if there's any abnormal immune testing. And that can help us determine what the severity of that immune abnormality might be. So we use various strategies of prophylactic antibiotics to reduce the frequency of infection in children with other immune deficiencies. And we use our experience in those other immune deficiencies to guide our recommendations for patients with Jacobsen syndrome. So if your children have recurrent ear infections and maybe a slightly low IgG that your immunologist doesn't feel requires immunoglobulin replacement, I think prophylactic antibiotics might be a great place to start to reduce the frequency of infections and get your kids healthy so that they can play with friends, go to school, and have less burden of disease. I really think patients who have low T cells or low T cell function would benefit from prophylactic antibiotics, especially if they have recurrent infections. And then one thing that I think Virgil and I, and maybe in discussions with Paul and with you today, think about adding some recommendations for the treatment or prevention of COVID-19. And in Virgil's talk, he alluded to some of the interventions that we have at our disposal. I don't want to talk too much about that because, as you know, it changes every week. I gave a talk in Pforzheim for the European group of families, and a lot of the information that I gave 2.5 months ago is completely out of date, right? They know that the treatment doesn't work against the Omicron variants. They've reduced the age or lowered the age of all the vaccines so that they're now approved. I think I said that you had to be 12 or over in May, and now it's down to 5, right? So, you know, it's a constant change. And I don't, because I know that this is going to live online for a little while, I don't want to give specific recommendations because they'll be out of date by the time I get home, probably this afternoon. But for you guys to know that there will be new vaccines on the horizon, probably specific for some of the variants like Omicron, right, to help protect our kids. There's currently a medicine in the US or an infusion called Evusheld that's approved for 12 and up, probably going to be approved for younger ages. That's effective at preventing, it's a monoclonal antibody, so preventing infections with COVID-19 in patients who are functionally immunodeficient. And then there's also an oral medication approved for ages 12 and up called Paxlovid for patients who are immunodeficient, but who have a positive COVID test and are ill. And on my flight up here, I got on my electronic medical record and sent a prescription to one of my patients who had just tested positive and who had X-linked agammaglobulinemia. Paxlovid is impactful and effective at reducing the disease severity and the infectious period in patients who are COVID positive. So those are some options, and I'm sure that there will be other treatments on the horizon. We have one question. Sure.
I'm sorry to interrupt. With all of the new vaccinations coming out,
Yep.
Is there a chance that we could over-vaccinate against COVID? Is there like a downside?
Yeah. So in terms of the downside for repeat vaccination, in some cases, right, or in most cases with vaccines, it requires multiple doses in order to get the maximum impact or effect of vaccination. In the first year of life, you get 3 or 4 tetanus vaccines because our immune system needs that reminder in order to be able to respond quicker and stronger to the next dose. There maybe some evidence that immunizing repeatedly doesn't necessarily have a downside, but doesn't really have any further benefit. A good example of that might be the use of Pneumovax in adults. So we can give Pneumovax to every adult who has respiratory disease or might be over the age of 55 or 60 to prevent pneumonia. But we don't give that vaccine every year. It doesn't have any added benefit. Instead, we wait and we re-immunize after 5 years when we know that that antibody level may have waned and stopped protecting people. The current mRNA vaccines for COVID are really unique and quite powerful at inducing an immune response. And they induce pretty good antibody production in almost everybody, including patients who have underlying antibody deficiencies. It's amazing how well the Moderna and Pfizer vaccines stimulated antibody production, even in patients with known immune deficiencies. The other thing that those vaccines do is they induce long-lasting or durable T-cell responses, which is one of the more important aspects of those vaccines and why they're so effective against COVID and COVID's disease. So even though the vaccines may allow for infection with COVID by not being perfect, they're really good at reducing the disease severity because of the way that they impact T-cell function and stimulate those T-cells to fight off COVID disease. So I don't know if there's a downside to repeat vaccination. And in fact, there's no evidence that there is any deleterious effects. There just may be no added benefit after some time. What may be more beneficial is development of novel or new vaccines that could target other parts of the COVID virus, right? Not just the spike protein, or with the new variants of the spike protein that might make those vaccines more effective. Just like flu vaccination every year. They change the flu vaccine in order to make it more effective. So I think that's probably what's going to happen with COVID, but a great question. Okay, I think so. Virgil, do I have one more slide? I think it's the question Q&A slide, right? No, we can skip this one. We'll just do questions. Okay, so I know we got questions and we've got Cole on the microphone. You can't see it, Virgil, but we've employed somebody to work the microphone.
My question is relating to, you talked about the fact that some 11Q patients or immunodeficient patients will start with a somewhat normal, possibly immune system, and then over time it will change. And we believe, or I believe, that Harlan is in that category where her immune system got worse as she aged. So it wasn't until around 17 that we found this out. So the question is basically, does that trend continue? Can we expect that if it started out as relatively good and got worse and worse and worse, even now that she's on IgG therapy, does it mean that she's going to have to be continuing to increase dosages or find new protocols, or her immune system will continue to tank or go in that direction?
You want to answer that one, Virgil?
Yeah, so if I understand the question correctly, the question is whether there could be a decline in immune cell function over time, and I think that is definitely the case in some patients. We also know that from, let's say, the primary immunodeficiency patients that we see on a regular basis, that this is something that may develop over time and may worsen over time. So that's also what we always tend to say, that in case, let's say, an initial evaluation of the immune system doesn't show any defects or any abnormalities, and over a few years of time, the clinical picture changes, or you still have the feeling that there is something evolving in the immune system, then a re-evaluation is required or advised. So yes, these are diseases or dysfunctions that may develop over a longer period of time and may be completely normal when you evaluate for the first time, but over repetitive measures could change. So in case of a strong suspicion of an immunodeficiency or a changing clinical picture, changing symptoms, then concluding, well, it was normal a few years ago, that's not the way to go. I think then indeed a proper re-evaluation should be advised.
Yeah, in regards to the antibody replacement aspect of it, I wouldn't expect the need to increase the dose based upon any worsening of that B cell function or immune deficiency. Once you're on immunoglobulin replacement, we make the dose changes based upon clinical response. And we wouldn't really be able to measure whether the B cells are making more or less antibody. And so we would adjust the dose just based upon the frequency of infections or overall health. And you're probably optimized already in regards to that dose. There's really no, the dose for immunoglobulin replacement is based primarily on body size and the patient's weight, not so much upon the original immunoglobulin or antibody levels.
You had talked about prophylactic antibiotics.
Mhm.
And we spoke yesterday and I told you that Harlan's skin infections
Mhm.
are still happening even with the IgG infusion. Would prophylactic antibiotics help with that?
Yeah, so Virgil, the question is for like recurrent staph infections, mostly areas of like folliculitis or cellulitis, and that may be due to like a resistant strain of Staph aureus, which I had 2 patients yesterday ask me about whether there's any use for prophylactic antibiotics. In other immune deficiencies where patients are at very high risk for staph infections, we certainly use prophylactic antibiotics to reduce staph infections. In antibody deficiencies, if a patient has some staph infection, I tend to treat with higher doses of the bacteria, of the antibiotic specific to staph, and maybe for longer periods in order to eradicate the bacteria. I don't typically use prophylactic antibiotics for staph, superficial staph skin infections, unless there's a really well-defined immune deficiency specific toward a risk for staph infection. Virgil, are you aware of any increased risk for staph or neutrophil function?
No, I'm not. Well, I see some patients that have skin infections, but I don't think there is a true, let's say, proven relation or association between Jacobsen or 11q disorders and an increased risk of staphylococcal infections. But I mean, I cannot rule it out that there is. It is indeed the case, but.
So for everyone in the audience, so it looks like the immune deficiency in Jacobsen is primarily T cells and B cells that don't function, and therefore antibodies that don't get produced. The phagocytes or neutrophils, that's the blood cell that they're also called like on your CBC, are the cells that are particularly important in preventing and clearing Staph aureus infections on the skin. That's why if you have an abscess and there's white pus involved in there, right? That pus is from the white blood cells called neutrophils, which have gone to kill the staph bacteria. And it looks like the neutrophils or phagocytes in Jacobsen syndrome function normally because they make that pus when you have an abscess. And Staph isn't typically a recurrent infection in Jacobsen, except in cases where you're colonized with it and it's in multiple individuals in the family. I think probably Virgil has gotten consults or been asked to see patients with recurrent staph infections, and we're unable to identify an immune deficiency that puts that patient at risk for staph. What we think, it's just a very bad strain of the bacteria, which is probably resistant to the current antibiotics. Staph is very catchy. It's highly virulent and very easily spread among family members, even in communities at health facilities. Wrestling teams have outbreaks of staph because they're touching each other during, during battle. So yeah, staph
I have a
is
second
terrible.
question.
Sure.
I have a question,
Okay.
just to piggyback. Out of all the doctors my daughter's seen, she's never seen an immunologist because she's never been sick.
Right.
So two-part question. In a regular blood panel, CBC, on a yearly basis, do they check the IgG, IgA, IgM levels?
Yep. It's a great question. They don't check IgG, A, or M levels unless you've seen an immunologist or there's a high suspicion and that test has been ordered. And that's why, even though Jacobsen syndrome was recognized for years and years and years, right? Unless somebody specifically looked for those immunoglobulin levels, it was never recognized that they were low because no one did the test.
So do I need to now get an immunologist? And I've never had a T cell or B cell
Right.
count as well, but she's never.
How old is she? She's 30. How old?
She's 27.
27. Yeah.
I never had one.
Yeah.
cold.
Not one. Yeah. So with a lack of, and I think Virgil's data shows there are patients with all normal tests, right? Yeah.
Yeah, so indeed, I mean, I think not all patients have an immune defect. I think the majority of patients I saw in a way have some minor or major immunodeficiency. But I think there are also, I know there are also people that don't have any signs of an immunodeficiency, so no recurrent infections. And also if you check them, you won't find any abnormalities. So I think also that is very variable between patients from zero to severe disease.
The only thing I had noticed is as she's gotten older, she did have warts all over, they all disappeared.
It is.
Now she's got the boils and those have increased.
It's interesting. So one other thing, I don't know if well, you can't pull the slide up, but his slide that shows the response to COVID vaccination in normal people, where most of the patients had very high antibody production. I don't know if you noticed, but there's a few people who look like they made almost zero antibodies, right? All vaccines have a known non-responder rate. So all the vaccines, for some reason, there are patients who get it, who don't respond to it and don't make antibody. But whenever we see that data that shows that in a big population of people, there are some individuals who don't make antibodies, we always think those are patients with primary immunodeficiency, right? Maybe those are individuals who just don't recognize that they have an immunodeficiency and are at risk for infection, but that the other parts of their immune system, Virgil's first or second slide talked about redundancy or complementation of, the other parts of their immune system covers up the defect and keeps them from getting sick. But in reality, they're at risk for more recurrent infections. Do you agree, Virgil?
Yeah, fully agree. Yeah.
Okay, cool. Oh, we got one right here.
Cold is the epitome of that stuff. He was on doxycycline for years. He's had cellulitis, the abscesses, everything you can see from his face still a little bit. But it actually actually has gotten better over the years. But one thing I want to say is he has eczema really bad.
Mhm.
I mean, where we had impregnated, I don't know, they were strips of
Yeah.
medicine. put on him. And we started Jacobsen about 2 years ago.
Yeah.
And
It's all gone.
he has some breakthrough once in a while, but man, it is
Yeah.
amazing. But I'm wondering would that help also with the respiratory because they, you know.
Yeah, so his risk for staph infection, if he did have severe eczema, that also is a risk factor for staph. The other thing to remember is kids with Jacobsen syndrome and other chronic diseases are in and out of hospitals, in and out of doctors' offices. Where do the resistant strains of staph live? In hospitals and doctors' offices, right? A lot of patients who get staph infections catch it when they're hospitalized for some other problem, right? So that's, methicillin resistant Staph aureus, usually hospital acquired, now community acquired methicillin resistant Staph aureus. So it's gone out of the hospitals and into the community. Okay, Cole, there's a few more questions in the back and then one right here. You couldn't see because you're getting a question from Paul, Virgil, just so you know.
Okay.
First of all, a huge thanks to both of you. I think this group appreciates fully your time and dedication and the impact that you've had. So thank you.
Before you ask the question, I'll just say that I think Virgil and I actually really enjoy coming to these meetings. It's probably one of the most rewarding things that I do, sometimes every year or every other year. And I always use my experience with both the US group and the European group when I teach medical students and residents and fellows that being a physician and taking care of patients in clinic and in the hospital isn't everything, right? That you interact with families outside of those domains. And sometimes that's probably the more rewarding than some of the other things that we do. So I thank you guys for having us because it's nice to feel, appreciated sometimes. So we don't always feel appreciated.
We are due for the three of us to have a beer next time.
We will, sure.
Couple things real quick. Going back, I think even to our 1998 conference when I just had a questionnaire, there was a somewhat increased frequency of eczema. So I think it was like 20% or so. The other question I have for you, I know we've had some email exchanges, but just if you could give an update on this. Up until now, at least, I've been recommending that people with Jacobsen syndrome, after getting the vaccine, you know what I'm going to say, get checked 6 to 8 weeks later to see if they did mount an appropriate antibody response. For July 7th, 2022, what are your most updated recommendations or thoughts about that?
What would they say in the EU, Virgil? You go first.
So the question is about the increased risk of eczema, right? That was.
Well, no, about checking antibody levels after COVID vaccination, like 6 weeks after getting Moderna or Pfizer, do you check for spike protein levels or anti?
So in general, we don't evaluate responses after vaccination, but I think it's very difficult in patients with Jacobsen syndrome, especially if you take into account that if you look at the immunodeficiency states, those patients tend to have a combined immunodeficiency, so with lower levels of antibodies or disturbed function of antibodies, and also many of them have a disturbed T cell response. And like you said, one of the major effects of vaccination should be the T cell response, or the in patients with combined immunodeficiencies that we have in our center, we evaluated antibody response and T cell response after vaccination, because we saw in a significant proportion of patients that they don't have antibodies and they don't have a positive T cell response. So we found it informative to know, because in those patients tend, well, I assume they are not protected against severe disease. So very long answer, but so in general, we don't evaluate response to immunization only in the patients with a confirmed combined immunodeficiency.
I'll agree. I think it's, I think that there's some benefit to checking for antibody production after vaccine, especially from a anxiety standpoint. So if you can demonstrate the production of antibody after vaccine, there may be a little bit of reduced worry. What we don't know is what that level of antibody really means, whether a level of 200 is enough to prevent infection, or do you need a 500 or 1,000? And also, we don't know about the durability of that antibody production, how long those neutralizing antibodies last, or at least the production that those antibodies. Because remember, vaccination isn't all about producing those neutralizing antibodies that will last for months and months and months. Vaccination is about inducing the ability for memory or for responses that are faster, better, and stronger with the next exposure to a bacteria or to a virus. It's not all about the actual level of antibody, because we know that that level decreases in all diseases for which there's vaccination. It's whether or not the level that becomes your baseline is adequate to prevent severe disease in the future. One more question in the back.
So some of us here seem to have kids whose immunologists said they have kind of a funky immune system.
Yeah.
But it seems to be working.
Yeah.
So my daughter is 7, and we have probably 15 specialists that would like to follow.
Just 15?
Just that would like to follow her every 6 months to a year if they have their way. And
That's just not, yeah, it's not happening.
It's too much.
Yeah.
So we are always looking for opportunities to kind of let some specialists go. So crazily enough, one of them is a hematologist, but also an immunologist. So
yeah.
We haven't seen an immunologist for our daughter since she was 2.
Yeah.
She's now 7. So she does get little things like that. She had Lyme disease, and she had the adult version of mono when she was very young, and then these little ingrown warts that she gets from swim lessons.
Yep.
How often would you say, or what should we do? Should we go back to the immunologist at some point? Is it just kind of like take it as it comes?
So I think that if you're, and I'll ask it because of the pediatrician part, Virgil. I think if you've seen an immunologist and the general evaluation was reassuring and the number of infections is relatively low, you don't need an every 6 month or 1 year visit to demonstrate that things look okay. Same with patients like DeGeorge syndrome is a similar disease. We don't have to see somebody with DeGeorge syndrome every year for their whole life. You know, once you've demonstrated that things are pretty stable, even if they're a little bit funky, right? So I would not be surprised if a lot of the patients with Jacobsen syndrome have a slightly funky evaluation. Their T cell number might be a little bit below the normal range, right? I mean, they might have 1,200 T cells instead of 1,300 T cells, right? But if those T cells and the B cells are talking to each other and your immunologist has demonstrated pretty normal immunoglobulins and the ability to respond to pneumovax, and that means things are reassuring. Now, if 3 years from now, your daughter has 2 sinus infections and an ear infection at the age of, 10, and a cough that doesn't go away, that would be an indication you might want to revisit things, because that means something is maybe changed.
And even though she will not talk for a very long time.
Yeah.
She does feel very
It's been, the evolution of those antibody deficiencies doesn't happen overnight. So I think you've got a window of a couple of years between evaluations, right? Virgil, I mean, you're not
Yeah.
gonna lose B cells overnight. That's
No,
just
no, no.
a slow sort of process.
Yeah, so in general, if you see, so we just previously discussing that indeed these kind of immunodeficiencies may develop over time, but indeed it's truly over time and not in a couple of nights indeed. So re-evaluation in, well, I think I would even say years as an interval than months or weeks or whatsoever.
Okay, I think we're out of time because,
We went out of time.
well, we have one question.
Oh, sorry.
Can we do one real quick and then Teresa's online? So do
I
her
just
talk.
wanted to check back in with, I followed through with Dr. Grossfield's recommendations to get the testing done after vaccination. And wanted to get you guys' opinion on the way the test results came back.
Mhm.
Was very strange. They kept saying abnormal for a multitude of days, and then sent an email saying that they got a positive, like kept as a positive abnormal.
Yeah, I'll have to look and see what it's, I'll look and see what it's reported at. Depends on if you ordered the right test. There's a semi-quantitative test, which actually gives you a number. Before that became clinically available, there was only one that told you whether you made antibody or not. And it wasn't actually antibody levels for the spike protein. It was for a different antigen that your immune system responded to. So it's apples and oranges, depending upon what test was run. So it's the most common question I've gotten about COVID antibodies over the last year or so. Okay, so thanks for your questions, and Dr. Mateen is up in a little bit. Oh, thank you. Thank you.